Good afternoon, everybody. I can see people starting to come through from the waiting room. So welcome to our session on myasthenia gravis. I'll just give people a few more moments to come through and log on. Still see a few people coming through, so I'll just give it a couple more seconds before we begin. Many thanks for joining us. Okay. Fantastic. So thanks everyone for joining us this afternoon. Welcome to Muscular Dystrophy UK's virtual information session on myasthenia gravis. I'm Rob Burley. I'm Director of Care, Campaigns and Support at Muscular Dystrophy UK, and it's my pleasure to be chairing the session, although I'll be doing so jointly with my colleague, Dr. Andrea Gubbis, who I will introduce shortly. We've got a really packed agenda this afternoon with a great array of speakers, and we're going to split the session into two parts. And we'll begin with a look at the latest developments around research into myasthenia gravis and a chance to answer any questions you may have specific to research. And we'll then move on to discussing living with myasthenia gravis and some of the activity around current treatments that are being appraised by the National Institute for Health and Care Excellence and other groups as well. And we'll also, again, we've got some questions in advance and hopefully some questions from you all who are with us live, if you're watching this live rather than the recording. There is a Q&A function, and to help us manage the session as smoothly as possible, we're using the Q&A function rather than coming to people live. So do at any point use the Q&A function at the bottom of your screen to ask a question to the panel. I will then play that back to the panel or provide a bit more further information. Before we begin, a note that our helpline is available to anyone affected by muscle wasting or weakening conditions. So do please contact us if you have any questions or are in need of any support, whether that's to do with anything that's come from today's session or just in general. We can either give you information and direct support or signpost you to the best place to go. You should be able to see the number and email on your screen, if not now then shortly, but you can call us on 0800 652 6352, or the email is info@musculardystrophyuk.org. And finally, a reminder that we're recording the session and it will be made available over the next few days. A real thank you to our sponsors today, Arginex and Alexion. So I will step away now from chairing duties and hand over to my colleague, Dr. Andrea Gubbis, to introduce herself and our research speaker. Andrea, over to you.
Thank you, Rob. So my name is Andrea. I work as a Research Communications Officer at MGK, and I'm very delighted to introduce our research speaker today. It is my pleasure to welcome Dr. Maria Isabel Leite from the University of Oxford. Dr. Leite is Associate Professor and Consultant Neurologist with clinical and laboratory experiences in the field of autoimmune neurology. Her focus is on patients with neuromyelitis optica spectrum disorders and autoimmune myasthenic disorders, with particular interest in myasthenia gravis and Lambert-Eaton myasthenic syndrome. She has a specific interest in understanding the interaction between pregnancy, antibody-mediated diseases, and treatments in order to improve patient care. Dr. Leite's academic activities include leadership roles in undergraduate teaching and in supervision of master's and DPhil students studying at the University of Oxford. She also provides clinical training and creates clinical research opportunities in autoimmune neurology for visiting neurology registrars, particularly from European and African countries. And now, without further ado, Dr. Leite, over to you.
Thank you very much. Should I now share my screen again? Yes. It is. Thank you very much for the invitation. I hope you can hear well. If not, please let me know. So I will speak a bit about how we understand immunopathogenic mechanisms of disease to then best treat the patients. These are my disclosures. and I work at Oxford in the myasthenia service, and which is an European reference network for excellence, and part of the University of Oxford. So what I'm going to tell you about is immunopathogenic mechanisms of myasthenia gravis, that is the autoimmune condition, according to the antibody status. And you know that great majority of patients will have AChR antibodies, others have the MuSK antibodies. It's the rarer form of disease. And I'll speak about their impact on the neuromuscular junction structure and function over time. We'll speak about key organs or molecules or cells relevant to standard and current therapies in myasthenia, and hopefully in future as well, and the relevant targets for immunotherapies used in recent and ongoing phase 3 clinical trials for myasthenia. If we go back to understand where our movement starts, when we move a muscle, when we show that we have strength in our muscles, where does it come from? Not only from the muscles or neuromuscular junction, but goes up to or comes from the brain. So if you see on the top, here is the brain, an area that is the motor cortex. Here you see in more detail. And from there down, along the brain stem that links the brain to the spinal cord, crosses there, comes to the spinal cord, and then along the nerve, and then links to the muscle. And this in this link here, the neuromuscular junction, where the problem is in myasthenia. So all the rest, the brain stem, spinal cord, the nerves, etc., that are all intact in myasthenia gravis. So this is in more detail. You see the axon terminals coming to the muscle, and there are lots of different areas of that junction. Each muscle fiber has several neuromuscular junctions. And the more active the muscle is, the more neuromuscular junctions they have. And I have to say that, for example, the diaphragm, that is a respiratory muscle, has plenty of neuromuscular junctions, and we can see them very well when we do in histology or so. We don't usually study or need to study the muscle of the patient's respiratory muscles, but is well recognized for many years. And in animal models, we can see that as well. So in more detail, that neuromuscular junction, or that link between the nerve and muscle, is here represented on the left. You see the end of the motor nerve, and then on the bottom, the pink part is the muscle, then is the nerve, where there is acetylcholine coming down, being released. This is the link, is the space between the nerve and the muscle. And this is called the postsynaptic membrane. This is a synapse, is the link. You have the AChRs here clustered, and others. And the acetylcholine comes and activates these receptors or links receptors and makes them activate and lead to the muscle contraction. So these are the AChRs here clustered, and there are other molecules. And this is the enzyme that is going to cleave the acetylcholine in two parts. And when the patients take acetylcholine esterase, such as mestinone or pyridostigmine, is to inhibit this enzyme and therefore keep the acetylcholine in much more quantity here, many more of these vesicles, and then increase the activity of the acetylcholine on receptors because many more molecules are available. So that's how the pyridostigmine helps is not degrading the acetylcholine, so much more acetylcholine is here. But what happens? So let's see the top there. Okay. Sorry, just trying to see on the top. I can't see very well what it says there. So the autoantibodies attack the postsynaptic membrane of the neuromuscular junction. And there are two main disease groups: the acetylcholine receptors that are of this subclass, AG1 and AG3. They activate complement, which then leads to the damage. It's not only a problem of binding, is that then they lead to damage of neuromuscular junction. We know very well that in this form of disease, the thymus is also involved, either in young patients with the enlarged thymus, or sometimes in a smaller proportion of patients when they have thymoma. And many of these patients have other autoimmune conditions. And then there is another subgroup of patients, a very small proportion, that have a different antibody to MuSK, that is a muscle-specific kinase. And those do not activate complement. And so there is dysfunction of neuromuscular junction, doesn't function well, but there is no proper damage, irreversible damage of neuromuscular junction. Here we review again, on the left, the normal neuromuscular junction, and on the right, you see now some, here what we call the acetylcholine receptor antibodies, which were formed by or produced by B cells or plasma cells. And then they come and they bind to the acetylcholine receptors and lead to dysfunction, and even more, they lead to the complement activation, which leads to damage of the neuromuscular junction. So there are three main mechanisms of action of the antibodies, but this one, complement activation, is the major and the worst because it leads to a disruption and damage of neuromuscular junction. And this is, the left panel is the same as normal, is that the MuSK antibodies. MuSK antibodies look the same as their antibodies, but they have a different target. They target, instead of being the ICHR, they target the MuSK. And the MuSK is recognized by having a role in clustering the ACHRs, and therefore they don't activate complement, but they lead to dysfunction of the neuromuscular junction by preventing or disrupting the clustering of the ACHRs, and therefore they can't work very well. So there is dysfunction without disruption or damage of neuromuscular junction. So as you can see now here, in the ACHR antibody disease, the postsynaptic membrane that usually, like here on the left, is folded very nicely. It's normal here, all these with acetylcholine receptors on the top, etc. Over time, and because the complement activation is damaging this membrane here, eventually it gets flatter and flatter with less capacity to recover. And therefore, when patients have disease for many years without having a very good treatment, or treatments that are lead to suboptimal improvement and leave the complement damaging the postsynaptic membrane, patients end up with this irreversibly affected neuromuscular junction, and then the symptoms may not improve. So this leads to my first goal, or our first goal, in treating patients is protect the neuromuscular junction and protect them from the antibodies or autoantibodies, because this is an autoimmune condition, and protect them from the ACHR or MuSK antibodies, but particularly the ACH antibodies. And where do these antibodies come from? So they are produced by immune cells. And here is just an idea. All of us have many, many types of immune cells. This is just an example of those that are relevant in myasthenia. We say antibody-producing cells, either for AChR or mask antibodies, B-cell lineage. So you have B cells that start as being stem cells, then pro-B cell is like growing, getting matured, and they are still in bone marrow. Then they come to circulation to the periphery. They are in the blood. They are immature B cells called plasmablasts. Sorry, the immature B cells, then naive B cells, mature memory B cells, if they have already encountered some antigens, and then they become plasmablasts and then plasma cells. And you see over time, the amount of antibodies they produce is increasing as they mature and they become plasma cells. So they can produce all good antibodies, all antibodies we need, but also some not so good antibodies, such as those that we have in autoimmune diseases. These are cells that express on their surface some markers. And you see in blue is from here to here, these cells express something on their surface that is called CD19. It's a marker of these cells. So if you have a medication that targets the CD19, will kill these cells. And so they stop producing whatever they have produced, including AChR antibodies or mask antibodies. While the CD20 expression is in a smaller portion of the cells, but still very relevant. Many of these cells have on their surface CD20. And so if we use a medication like rituximab to target the CD20 positive cells, they are killed, and ideally or potentially they eventually reduce formation of AChR antibodies or mask antibodies, and therefore they help with disease manifestations. So our goal too, in terms of preparation for treatments, is reduce the antibody production, antibodies in circulation, and their pathogenic effects. So as you saw, a number of B cells can produce antibodies or plasma cells. So our goal is to reduce those cells of producing antibodies, so we have sometimes kill them. But other medications can also reduce the antibody production and antibodies in circulation and reduce those cells. And this is the standard steroids or immunosuppression. Those are not targeted. They reduce grossly the immunosuppressed patients overall doesn't target particular molecules or particular cells as rituximab do. So why does immune system produce antibodies, the autoantibodies? Why does this are produced? Antibodies against AChR or others. If I go back a second, in mask myasthenia, we don't really understand where the mask antibodies come. But because majority of patients have AChR antibodies, that's what I'm concentrating now. And we know that in many patients, the thymus is involved in myasthenia gravis. And the thymus may be abnormal in these patients. That's why some of them need to be operated. Thymus is a gland, immune gland, that is located in the chest, just anterior to the main vessels, just above the heart, between both lungs. It's called thymus. It has two lobules, similar to thyroid, but larger. You see thyroid above and trachea. And so the thymus is important in the immunity to help us to to identify our body and our cells, etc., recognize them as self, and so not be attacked. But sometimes our immune system, and starting by the thymus, the immune system lose the ability to self-identify itself and produce antibodies against the self-antigens, such as the AChRs in the neuromuscular junction. So in myasthenia, the thymus can be normal, especially in older people. And so in older people, we don't usually do thymectomy. A large thymus that is not a tumor is called hyperplastic thymus or thymic hyperplasia, is more recognized in younger people. So people who have disease onset from early age to around 50, or sometimes a bit more, they are still called young. And some patients, around 15 to 20% of patients with ACH antibodies, have a tumor of the thymus that is called thymoma or a thymic malignancy. This is just a picture from microscope of patient of the thymus from patients who do not have a thymoma, but they have, for you to compare, the control thymus on the left that is normal. On the right, and the end of the right side is the thymus of a patient with MuSK antibodies, also normal, while these ones have patients with ACH antibodies, and you see this formation very enlarged. Doesn't seem to be here in the picture, but they were large, and they have this type of areas with germinal centers. They look like lymph nodes, here the same. And what thymus has is particularly interesting is they express a type of muscle cell there that is relevant in the autoimmunization against AChRs. So thymus is full of lymphocytes, it's full of epithelial cells, and have many antigens, some molecules that are the same as we have in periphery. And interestingly, it has myoid cells that are cells that look like muscles. And by being in that environment surrounded by B cells, T cells, etc., particularly T cells, they seem to be probably the origin where the autoantibodies are first formed, or the cells that will then eventually produce antibodies come from. That's what happens there. So that's the main reason why the thymus is removed in patients who do not have a thymoma, to see if we can stop priming the immune system to produce antibodies. And that's why we usually say the thymus should be removed in the first months after diagnosis, to not let the immune system be already prompted for very long. Because if we remove the thymus very late, then doesn't have probably the same impact as if it was removed early on. Therefore, our goal 3 is reduce or stop the trigger to the autoantibodies to be produced to AChR in myasthenia, to stop the autoimmunization process, and therefore subsequently perpetuation of the autoimmune attack. That's what I have to say today. So in summary, I went back to this, but I can now stop sharing and go back and say that in regards to myasthenia, and it's important for patients to understand that after we diagnose the patient with myasthenia, our goal, and above all, the patients, is to improve. And we can only improve if we act fast and target what is wrong with them. Is a problem in the immune system, produce cells that can attack the postsynaptic membrane, and then go back to the thymus, where majority of patients with ACH antibodies have probably an abnormality, by removing the thymus, we can go to the origin of problem and then help to improve. That's my main message today. And thank you very much.
Thank you so much for your fantastic talk. I have enjoyed it, and I would say that everyone else probably did. So I would like to open a Q&A session. So please do ask any questions you might have for Dr. Leite. And I always like to say there are no stupid questions. So if you're interested in anything research or science related, myasthenia gravis, please do ask Dr. Leite while we still have her here. So I will start with the first question to try and get the discussion going. So in my opinion, so in my knowledge, myasthenia gravis is not inherited genetically, right? So how does it come to this? So you explained that it all starts in thymus. So how is one just born with it?
Yeah, that's a very good question. And in majority of autoimmune conditions, it's even harder to explain because here we have the thymus. That's probably the main driver for the condition in young onset myasthenia patients and thymoma patients, but not in MuSK antibody disease and not in many other autoimmune conditions. So it's quite tricky. I think it's a combination, we all think it's probably a combination of genetic predisposition plus some environmental factors that we don't know which ones are. Is a very difficult question to answer about any autoimmune condition. Why and how it happens. All of them more or less around the same age. So there is in particular in myasthenia and many other conditions, you know that in younger people, they're predominantly in females, whether hormonal things also play a role or other factors, then environmental as well. Because, for example, we have patients with, I was going to suggest or say that in MuSK myasthenia, we have very rare patients, but in Mediterranean areas, there are many more patients, still rarer than ACHR. So it's very likely a combination of immune genetic factors that the people have, they are born with, and then some environmental factors on the top of that. And in addition, the ACHR antibody is those factors associated with the thymus pathologies probably also adds to that that autoimmune predisposition.
Yes, guess please, yeah, Amanda.
Okay, I was diagnosed when I was 26, and I'd been really, really fit, very fit to the point that I was going to the gym 3 or 4 times a week. Then I went on holiday and had vaccinations, maybe primarily typhoid and cholera. So this was in the October. By the December, I couldn't talk, I couldn't walk, I couldn't eat. It came on dramatically. So I just wonder whether there's any feeling within the scientific research community, whether there is a factor with vaccinations, or would I have had a predilection to maybe MG, and this just kick-started it? That was my question.
It's a very good question, and many patients experience the same. May I ask, do you have ACH antibodies or MuSK?
Well, ACH, okay. Yeah. Well, I will say I've been immune suppressed for 30 years now, and actually I don't show any antibodies at all now. Okay,
but you still have symptoms?
Absolutely, yeah, and I'm having plasma exchange and IVIG.
Oh, wow. Okay, so many patients report an event around the time of that developed myasthenia, and the vaccinations or infections are the most commonly reported events prior. And it's very likely that's not exactly the infection or the vaccination itself, but predisposition. Probably be developing myasthenia later, years later or so, but because that, those trigger the disease and probably to come earlier or to develop either. Because when we receive a vaccine, our immune system gets activated and produce antibodies against that bug or whatever the vaccine is for. And so the same with an infection, you have an infection, your immune system reacts to that, could then lead to some autoantibodies that are not against or are similar to that bug or vaccine, but then affect the muscle. It's possible, is rare to be seen as consistent event, otherwise would start thinking there is a clear link. There is not a clear link between vaccines and autoimmune conditions, but the predisposition to an antibody-mediated condition can be the factor that leads to that trigger. So some people have start disease after, I said, an infection, a vaccine, be positive, an operation, be another life event, but the vaccines are really recognized as not only to trigger or to be around the time of the trigger, but also can contribute to worsening of the symptoms when the patient has already disease.
Can I follow that on? Sorry. Can I just follow that on with this, the fact that I am negative to antibodies now, although was originally, I originally had antibodies. Is that something that does happen after years of immunosuppression?
Yes, it can. What I find is usually when the patient, the antibodies go away, usually the patients are better. And so the antibodies there, you have symptoms, you are treated. Great majority of patients remain with antibodies there in circulation, but they are under control, so disease can be well controlled. In some patients, the antibodies disappear, so we can't detect them. And those, when I see that, usually is in patients that have disease very well controlled, like being in remission. It's less common to have no antibodies detected and the symptoms be very obvious and very bad, because you need plasma exchange and IVIG regularly. That sounds, yes, something. Whether there is some other problem there, I don't know. I can't explain very well, but it's possible.
Thank you. Thank you.
I believe you were tested for MuSK antibodies as well.
No, I've not been tested for MuSK antibodies. No, not at all.
And you had thymectomy as young?
I did when I was 26, but the thymus was normal. There was no growth there. There was no antibodies in the thymus. No, there was nothing wrong. It was a normal thymus.
Okay. It's just a simple observation that in patients who have symptoms and have no antibodies for AChR, even they had before or so, I request for a MuSK antibody just to make sure we are not missing anything.
Yeah,
it's just an observation.
No, thank you for that. I'll pass that on to my neurologist. Maybe that's what will happen. But appreciate that. Thank you.
May have happened and probably long ago, and you may not remember. Okay.
Maybe. Thank you.
Well, thanks so much for the discussion. I will close the research session now, but I will hand it over to Rob so we can continue the discussion on myasthenia gravis. So I would again like to thank Dr. Leite very much for her seminar and her talk. Rob, over to you.
Okay, thank you.
Before we let Dr. Leite go, I can see Tracy has her hand up.
Sorry, I'll be on. I'll keep it on, but without my camera, so I can to the other computer and do my letter. But Tracy had a hand up.
Yeah, just a very quick question. Is there a link between the level of antibodies and the severity of myasthenia symptoms?
It's a good question. They're all good. Yeah, in one individual, if you see one individual, the patient itself, they have their own level of antibodies in general, let's say. And if you have a certain level, doesn't matter what it is, as you receive the treatment, the antibodies should come down. And so as you improve, etc. Doesn't always correlate exactly. Like, let's say, if the antibodies come down by 50%, doesn't mean you are 50% better. You may be 100% better. You may be 75% better. But in general, yes. But then you could have fluctuations of antibody levels because it relates to so many different things, and probably your symptoms are the same.
Okay.
But in general, yes, there is. Then when we cross patients, so if we have many patients all, this correlate at all. You can have patients with very high level and being well, others with very low level and being very symptomatic. So that is the main thing. You have your own level of antibodies and the strength of antibodies. You may have lower level, but very, very strong, let's say, their activities, they are all there in the neuromuscular junction. Others may be all in circulation and floating there and may not be doing much, or have a different mechanism. As I showed you before, you may have antibodies that not activate complement so strongly, and so they don't damage so much, they don't cause much, or may have fewer, but very activating complement, and they may be very damaging, and patient is more symptomatic.
Thank you very much.
No problem. So I'll have my camera off, but I will be paying attention. Thank you so much. Thanks, Shannon. See you soon.
See you soon. Thank you very much.
Thank you, Dr. Leiter. That's a fantastic presentation and great to have you with us. We promise we won't test you by sort of dropping you in it with a question sort of planted in half an hour or so. So thank you for staying with us. A reminder that if you're joining us as an attendee, you don't have to be a panelist to ask a question. Do please use the Q&A function and I'll relay them back to the panel. But we're now going to move into the living with myasthenia gravis section, and also a bit of a discussion about current activity around availability of treatments. I think what I will do is introduce the panel individually first before moving into discussion. And if I introduce each panelist and just ask just a couple of words to build on how I introduce you, so A, to make sure I've got it right, and B, just to share kind of your role in supporting people or working with people with myasthenia gravis. And then I'll move us into a discussion about treatment, the current sort of treatment appraisals, and then some questions in general, sort of discussion about living with myasthenia gravis. So I'm going to keep it easy on myself and do it in order of who's on my screen and what order. So starting in my top left, Dr. Channa Huamadama is a consultant neurologist with specialist interest in a broad spectrum of neuromuscular disorders, including myasthenia gravis. And he's also the co-chair of the Yorkshire and Humber Neuromuscular Network he's based in Sheffield. Also leads clinical trials in several conditions, including myasthenia gravis. So Channa, I know you lead a recently acknowledged Centre of Excellence service in Sheffield. So just great to just a couple of words about your role and how you support patients living with myasthenia gravis, if that would be okay.
Thank you, Rob and team, for inviting me to this webinar. So I lead the neuromuscular services in Sheffield, and in Sheffield we provide the regional myasthenia gravis service for Yorkshire and Humber region, and our myasthenia catchment expands to about 5.2 to 5.9 million people. So we have quite a large population of myasthenia patients, and we provide an hub and spoke type of service. We see them in our clinic as well as support the referring clinicians from the referring hospitals. We do have neuromuscular nurses to support myasthenia patients, and recently we established myasthenia gravis research nurses to help the clinical trials, because you know that there are a number of clinical trials in myasthenia gravis which have been active in the UK since about 2018, 2019 time. And so it's quite an exciting time for myasthenia gravis, with lots of new therapies coming through the pipeline. In addition to that, I also support NICE and NHS England regarding myasthenia gravis novel therapies in trying to get these therapies established in the UK for UK patients to access.
Brilliant. Thanks, Chana. Much appreciated. Amanda, you're next on my wheel. So Amanda's already alluded to her experience of living with myasthenia gravis, but Amanda, you're also a peer support volunteer at Vascular Dystrophy UK. You run our kind of support group as well, and you've got lots of other hats on. But yeah, do you want to just introduce yourself and your experience? I think you've also been a patient expert with NICE, haven't you, as well? So you'll have a sort of slant on that as well.
2 occasions. I have, yes. It's been an experience for me working with NICE, and I feel very special doing it, or being asked to do it. I've had MG for 30 years now, and we've set up a little group with Muscular Dystrophy UK, as you say. I try to help as much as I can, and basically that's it, really. I've been on a couple of boards now that you've introduced me to with Fit Access, and that's where I am really going forward. Sorry, it sounds very boring, to be honest, but that's what I try to do as much as I can, really support anyone with myasthenia through Muscular Dystrophy UK.
Thanks, Amanda. Not boring at all. We're delighted to have. We've been working very closely over more than a year now, Charlotte and Tracy, together on treatment appraisals. So between MyAware and MD UK. Tracy, you're next in my wheel. So Tracy is with us from MyAware, but also lives with myasthenia gravis, and has been working with MyAware for about 7.5 years in a sort of support role. Tracy, I don't know if you'll just say a few words about yourself and about MyAware, as you're the first MyAware speaker.
Yeah, of course. And thank you for the invite today. It's lovely to be here. So I've worked with MyAware for about 7.5 years in a support role, now currently a national support coordinator. Our support changed after the pandemic, and we now support our members nationally. We support them online, one-to-one, phone calls, emails, however we can. We have Facebook groups and social media that we look after members with. We hold webinars and Zoom sessions, and yeah, I have a bit of insider knowledge because I've lived with the condition for just over 20 years now. So not as long as Amanda, I know, but also alongside Amanda, I've been involved with a NICE project as well. So it's lovely to be invited, and certainly in the 20 years that I've been diagnosed, it's great to see all the research that Chana's talking about and that Charlotte's involved with. It's a very exciting time, and I'm very, very pleased to be working with MyAware and be able to share all this with you today.
Thank you, Tracy. That's fantastic. And then last but not least, Charlotte, it's great to have you with us. Charlotte is the Research and Partnership Officer at MyAware. So he works quite closely with us on our treatment appraisal engagement and leads some of that work as well as part of the partnership. So yeah, Charlotte, over to you if you introduce yourself and your role at MyAware.
Yeah, please. Thanks, Rob, and thanks for the invite for being here today. So I've been with MyAware nowhere near as long as Tracy, actually. I'm still kind of babies of the group. So it was October 2022 for me. And as Rob said, I'm the Research and Partnerships Officer there. So my role is quite happily split between managing our research program as we fund a number of clinical research projects involving the different myasthenias. And then in terms of partnerships, our relationships with external organizations and other patient groups for myasthenia worldwide. So it's a really exciting job, especially right now with the current pipeline, and as Rob said, helping out with NICE projects that are coming up. So that's me.
Brilliant. So thank you. That's our panel. So yeah, before I move us into then a discussion about sort of other areas, several people and including Dr. Lightham have alluded to this being quite a potentially quite exciting time in terms of developing a new wave of treatments for myasthenia gravis, and certainly potentially ones that are a bit sort of more easy to receive as a patient. So we've been involved in a lot of that work together with MyAware. you might notice I'm stumbling because I've just lost the document, but I've got it now. From the patient, if I start by giving a bit of the patient advocacy group perspective and invite Charlotte to sort of join in after that, but then maybe turn to Chandra in terms of the sort of clinical view of where we are with the treatments. I think it's fair to say recently MyAware and Muscular Dystrophy UK wrote to NICE and to all companies involved in current appraisals. So there are sort of 4 appraisals, but one has recently been terminated for treatments, just to express the view of the community that actually last year felt like quite an exciting time. There were 4 treatments coming through the appraisal process, and actually we're slightly concerned that the way that the way that they're being presented at NICE, or some of the barriers in terms of the evidence gaps, may actually mean that some of them aren't approved. And indeed, at the moment, we're in a position where one of those treatments, efgartigimod, currently has a draft guidance. He says carefully, draft guidance that is not to recommend it for use on the NHS. And I think a key thing with these sort of this new wave of treatments, there are 4 that we're sort of talking about. So there's efgartigimod, there's ravulizumab, though that's recently been terminated by NICE, zilucoplan, and rosanoximab. That was a terrible pronunciation of that one. But in effect, these are often described by patients as being a bit of a cleaner treatment and have clinical benefit, but maybe less side effects than the traditional treatments that are currently undertaken. Interestingly, Amanda, you mentioned IVIG as a kind of one of the things that you're experiencing at the moment. And that's been something that's come up in the appraisal processes in terms of how available that is and kind of how that's used as a kind of maintenance IVIG versus emergency IVIG. And sort of the perception of the patient groups is that there is a strong clinical evidence of their effectiveness, and then also when we go out to the community who have had experience of treatments and also about their experience of the condition, there's a strong sense that the treatments are needed by the community, that those who have received them, particularly efgartigimod in terms of having access to an early access to medicine scheme, certainly perceive real benefit for the people on them. And indeed, the draft guidance for efgartigimod, that again, draft guidance, but it doesn't recommend it currently for use, acknowledges that clinical trial evidence suggests that efgartigimod plus standard treatment improves symptoms and people's ability to carry out their normal activities compared with standard treatment alone. And that's a direct quote from the NICE document. And just to share one of the quotes that came to us from the patient community around efgartigimod, an individual shared with us that I started efgartigimod and the improvement was immediate. The thought of going back to the way my life was before this treatment scares me. I finally felt like I was getting my life back after 3 years of hell. So that's kind of, and we've gathered those insights into efgartigimod because that's the treatment that's furthest down the appraisal line. We'll be doing the same thing for the other treatments I mentioned as well. But that's just an illustration of kind of the sense of motivation within the community that these treatments potentially do become available sort of through a positive, NICE recommendation. So before I turn to you, Chandra, we're just maybe the kind of the clinical view of those treatments. Charlotte, I don't know if you want to add anything in terms of your engagement with the community and your experience of working on those appraisals together.
Yeah, I would. Yeah, thank you. So I think for us, it was important to write this letter to NICE because MDUK and MyAware have collectively put together a lot of strong patient testimony regarding not only the effect of the medication that's being appraised right now, efgartigimod, but also what the current landscape is like for patients with myasthenia, what the treatment options are, and the length of time it has been before since there has been any sort of new developments, and the strong unmet need there is for therapies that are targeted to myasthenia, that aren't more of a blanket approach with some strong off-target effects like we see with steroids, and for a treatment that, can make a quick and really effective difference in people's lives. So that was sort of the main goal for us, was to kind of tie that all up into one firm statement from both parties. And we just hope that the companies that received the letter and NICE take into consideration with the ongoing discussion. That's me.
Thank you, Charlotte. And Chandra, yeah, it'd be great to hear your kind of perspective, because I know you've been a clinical expert within some of those appraisals as well, but also I know you have had experience with some of these treatments and just the treatment landscape in general at the moment.
Yes, thanks, Rob. I think I agree with my colleagues in myasthenia gravis particularly. There are 4 clear unmet needs. We need safe, fast-acting, targeted therapies which have evidence base. And that's what the latest clinical trials, which have concluded, and they backed up efgartigimod, rozanolixizumab, ravulizumab, eculizumab, and zilucoplan. They got very strong evidence base behind the clinical trials that they concluded. And these are novel therapies, and they're clearly targeted. When you look at the evidence, they're fast acting within 2 to 3 weeks. We can see that the patients are benefiting as indicated by patient-reported outcome measure MG-ADL. I had the fortune of using a number of these drugs through clinical trials, and the recovery of these patients is unbelievably quick and sustained. Particularly the complement factor inhibitors that we have used, and unfortunately in the UK we couldn't recruit to efgartigimod a myasthenia clinical trial because due to pandemic that the sites were closed. However, I have access to this drug through the early access to medicine scheme, which we have used in a number of myasthenic patients, as well as I use it in other autoimmune conditions, and the benefit the patients receive is remarkable. You don't have to wait for months to see the benefit. You can see that within a few weeks. Communicating to NICE the unmet need in myasthenia gravis, I think the patients and the clinical experts who are there, we did communicate that in no uncertain terms. The NICE process, as you're aware, they look at what's the most cost-effective model that they can adapt to recognizing these therapies as standard commission treatment on the NHS. So there is negotiation between the NICE and the drug company or the sponsor, with the help of information given by the patient experts and the clinical experts. So this is, in other words, it's a bartering process, and in that process, clinicians and the patients do have a role to play to tell NICE to inform them appropriately that.
I think Shannon, we may have. Oh, sorry, Tanner, you froze briefly. Sorry, go ahead.
I do not know which bit you heard. What I'm saying is that clinical experts and the patients have a role to inform NICE about the unmet need in myasthenia gravis, because our patients have been treated with age-old drugs which don't really have a strong evidence base, like mycophenolate, the methotrexate, the tacrolimus, etc. Azathioprine does have some evidence to support, but we all know that it takes about 12 to 18 months before you know that it is working. So that's the time that we are allowing our patients' neuromuscular junctions to be destroyed and perhaps make the disease even more resistant with time to come. Because the treatments for myasthenia gravis have come about in the last couple of 2 to 3 years, and that they are now hitting the NICE pipeline, there is also a learning process for the patient groups, the clinicians, as well as the sponsors, how you could articulate this problem to NICE. Because NICE, to be fair for them, it's not only myasthenia they deal with so many other conditions and hundreds of drugs going through their pipeline. So articulating our message and letting them understand the gravity of it is key. So I think regrouping patients and patient charity and clinicians is what is needed to ensure that we have. I'm sure you guys, together with Maya, are doing a tremendous job in this, and I will help as much as we can. And there are other clinicians we have got together recently in Birmingham, and we had a discussion of how else we could help NICE understand the challenges the patients face, designing a pathway. There's a group of us who are reviewing the the guidelines for myasthenia management and the treatment pathway. So it helps NICE develop confidence that that clinicians will use these novel therapies responsibly and ensure that the right group of patients receive these drugs, and we monitor their progress and stop the treatments if they're not really progressing, benefiting, etc. So there is a body of work we are doing, and there's more to do. But I would like to hear others' views.
Thanks, Charles. That was incredibly helpful and very clear. Staying with treatments just for one more round. Amanda, it'd be great to hear from you, because actually what MyAware and MD UK have done together is sort of pool the patient experience of the condition and the treatments. But then actually what is very important is actually when it comes to the NICE committee, when they sit down and discuss the treatment at their meeting, there's a patient in the room with them, or virtually in the room with them, and that has been you on a couple of occasions. What's that experience like as a patient, sort of being in the committee room? And do you think that sort of NICE, the committee, sort of our understanding of myasthenia gravis as a condition? So aside from the debates around cost effectiveness and evidence, actually, do you feel that they understand the condition and the impact it has on your life?
I think so. It's very intimidating. I feel that I can't let the community of people with myasthenia down, and I feel I need to get across. And I do think that they listen. I know Tracy has been on the committee as well, and I do honestly, the questions they ask, yeah, I think personally that they really do listen, but ultimately it doesn't matter what I say, because it's always going to be down to money. Unfortunately, fiscally, sometimes these things don't work because of how financially the impact is. I personally feel that Tracy might have another view, but I do think that they listen. Yeah, I do.
Yeah, Tracy, do you want to come in on that as well then?
Yeah, I agree with Amanda. I do have a slightly different view on the fact that when we were engaged with NICE and we were sent a questionnaire on our journey with myasthenia, it was very, very in depth. And I think both myself and Amanda were very honest with how, with the treatments that Chana mentioned that have been there for the last kind of 20, 30 years, the side effects of those and how that affects your life going forward. And as Chana says, once you've been on azathioprine for 18 months and it doesn't work, so then you start your mycophenolate for another 18 months and that sort of thing, was all very much explained in the writing of our application, if you like. On the day, I don't feel there was enough time to speak about that personally. That would have been my feedback from the session that I was on. Again, it's a very nerve-wracking experience when you're virtually in a room with all these experts who have the power to say yes and no. And like Amanda, I was not only representing me, I was representing, everybody with myasthenia, and I wanted to ultimately do my best. And I would have liked a little bit more time to kind of explain rather than just have the written word. But
Yeah.
Hopefully going forward, if there are some more opportunities, then we will. I will certainly try and do that. I don't know if you felt the same, Amanda.
I do, and I certainly expressed that in the questionnaire that I was sent, and I did feel that some of the questions, I don't know whether you felt the same, were quite, they weren't as well, crumbs. They could have been better written. In depth,
yes,
exactly. Sorry, yeah, in depth. They certainly weren't. There wasn't enough there. No, enough questions were asked, especially because MG is such a vague, shall we say, condition, and it's not, you can't put it into a box.
No, it's hard to explain, and I'm sure it's hard to understand. Equally, it's hard to live with as well. So it's tricky in that sense.
Yeah, absolutely.
Yes, I think patient experts who are there did their very best given the circumstances. The NICE particularly will have not much understanding on the lived experience of myasthenia. So I think emphasizing the the major morbidity, for example, major problems of myasthenia, such as is completely unpredictable and is fluctuating. It's not like another disease which perhaps might be progressively getting worse. So you are going to expect the worst. I'm not putting in a relative term, but emphasizing the fact that it is unpredictable, is fluctuating, and even if you're well, you do not know when the next exacerbation is going to be, and current treatments don't necessarily help prevent those exacerbations. So educating NICE, perhaps communicating that message, how a life that is unpredictable is distressing, and then also the side effects of steroids. Now, NICE would have heard about this story from rheumatoid arthritis or from lung diseases, etc. But bringing on the fact that in myasthenia gravis, when we start high-dose steroids, they are on high-dose steroids for months on end, and people go from being very slim to significantly they gain weight, and their bones become weak, and then you're dealing with side effects of steroids. Communicating perhaps those aspects of current available poor therapies and their side effects probably is also necessary in a bit of a, I would say, it need to be delivered a bit more strongly, and how, and then together with that, how people with who are on novel therapies, we are able to reduce steroids, they're able to become stable in their condition, and how that differs. Drug medication use for years, how that compares could be communicated to NICE. I think I'm not sure whether Amanda has been on any of the new therapies, or there was one patient who was on the panel who had been on a new therapy. Mm-hmm. At the same time, Rob, I was wondering, is there only the opportunity for 2 patients to be on the NICE panel? Could there be more patients, or perhaps Myaware or MD UK to represent patient stories? I'm trying to draw from the experience that I had in supporting SMA, spinal muscular atrophy. We had very expensive therapies approved for a very disabling group of patients. And we have been able to bring the drugs from brink of being not approved to being approved. Learning from that experience, when as clinical experts we were losing our voice, the patients did, I feel, bring it back from the brink. So I can probably talk to you all outside this meeting and discuss which elements of information, if rather than the same 2 patients or 3 patients telling the same story, but aspects of the disease can be focused. One talks about the unpredictability of the nature of the condition, how they have suffered for so many years, and another person the side effects of the treatments, so that they get NICE understands that actually this is a terrible disease. Maybe we should try and negotiate a little bit more favorably, and try and see that we get this drug approved for a specific group of patients, rather than thinking it's a blanket no, I'm sorry, it's too expensive, this disease can be managed with existing treatments. I think probably when NICE disagrees with the appraisal, or when they turn it down, in other words, they're agreeing with the existing therapies enough for our patients, which is not. And I also don't want NICE to consider IVIG and plasma exchange is an alternative therapy. It is not. It is only ideally, and it's on NHS England only commissions that for crisis management.
Absolutely. I think it's the NICE process itself. I'll come to Amanda in a second, and Tracy in terms of their experience of it again. But NICE have become quite tight on the kind of the 2 patient experts at the committee meeting and the 2 clinical experts at the meeting. I think with the SMA treatments, that was sort of, that was nearly 5 years ago now, wasn't it? So 3-5 years ago. So I think they sort of tightened up that process a little bit. Indeed, with the current multi-technology appraisal of 2 of the SMA treatments, even though there's 2 treatments going through, they're still at the moment, I think, holding to the line. There has to be only 2 patients as experts on at the committee meeting. I think what we've done with MyAware, we've done very powerfully, I think, is that's where we come in as the patient groups, is to support the patients in the room. So we have Francis was the efgartigimod, one of the experts who had experience in the treatment as well. So working in partnership with your colleagues, Chana, we were able to locate someone who was willing to talk about that experience of the treatment, having received it. And I think she was a very powerful advocate in terms of her direct experience, not only of the condition, but the treatment, but also in terms of gathering the views of the community through our joint responses through each stage of the process. So those aren't sort of published until the end of the process, sort of strangely. But we put forward some very powerful testimonies from the community, which includes the quote I sort of shared earlier. But it'd be great, very happy to link up. I think kind of the role of patient groups, patient advocacy groups, in the words of NICE, is to be a bit of a kind of linchpin between the company, NICE, NHS England, and the clinical community as well. So very happy to kind of keep playing that role. Yeah, absolutely. Charlotte, I don't know if you want to add anything in terms of the perspective of being a patient advocacy group, supporting patients through the process and also engaging in the process as well.
Yeah, I think it's a kind of a careful balance, because we're people that are a group that are able to engage with NICE, engage with the company, engage with patients, and trying to make sure that the patient voice is getting promoted as best as possible. I think what we've been doing recently and trying to encourage people to leave independent commentary on appraisal, on the draft guidance, and trying to help folk out if they've never commented on a NICE document before, from a technical, but also breaking down sort of the key points of the appraisal itself. I'm kind of hoping that there is a lot of interest in that from the community, so that it's not just so much us representing many voices, but many voices representing themselves with our assistance and helping getting that promoted. It's been a new experience for me. It's not something that, obviously, of being new to my role, it's been a journey so far, and I am just hopeful that we can get things pushed through, and that we have a similar sort of result to the SMA community if we can get the patient voice promoted as best as possible, because I know the clinicians are also doing everything they can to emphasize what these unmet needs are for our community. So.
Yeah, thank you. I'll do one final plug for the way to get involved with some of these proposals before I move on to another topic on living with myasthenia gravis. So a slightly strange, I think, setup in the NICE process is that as a member of the public or someone living with one of the conditions, you can only directly share your experience with NICE after there's been a no. So that's why our role as sort of MyAware and MDUK is so important in terms of being the kind of conduit for views in. Because there has been a no for efgartigimod, or a draft no, there is currently a consultation underway, and Charlotte has led on producing a guide for patients on how to take part in that consultation, which you can find on the MyAware website, and also it's shortly will be on the MDUK website. That consultation is open until the 29th of February. So as well as sharing your views with us, you can actually at the moment share your views directly with NICE through that consultation. I probably need a disclaimer that the reason we're talking about the efgartigimod process so much is because it is that much further down the line, and there are now mechanisms to take part. That will happen sort of later with the other 3 treatments as well, as they progress. So definitely worth sort of plugging that to take part in.
Yeah, is it okay if I post the link to that?
Yeah, definitely. And if we can't, if it doesn't come through on the Q&A, oh, there you go. Yeah, if it doesn't come through on the Q&A, we'll post it on the YouTube recording of this when it goes out on YouTube, and also send it to attendees as well. Chana, you touched on this actually in one of your comments about why the treatments were kind of such a kind of could potentially be quite a game changer, but just in terms of that stability and the fluctuating nature of myasthenia gravis. And indeed, I remember one patient, I think it was in the efgartigimod appraisal, talks about just the fact they can plan to go and see family 1 month from now because they kind of have a fairly confident view for the first time of how they'll be. We did have a question in advance, which is someone who was worried that their condition fluctuates from day to day, and just wondering if that's a normal experience of the condition or whether there might be something some underlying going on. It's my understanding is that's quite common, but yeah, Chan, I don't know if you want to answer first, but then go to share, then I'll go to Amanda and Tracy to share their experience.
Indeed, it's particularly those patients who are symptomatic with myasthenia gravis, and their condition can fluctuate throughout the day. Some patients, in fact, they feel worse in the morning, although this is not typical of myasthenia gravis. We tell our medical students that they tend to get patients tend to get weaker and tired as the day goes by. That might be true when someone presents to you, but when patients are being treated, because they perhaps sleep overnight and they don't take any medications, the pyridostigmine could have worn off, and they feel quite symptomatic in the morning. They cannot have their breakfast or have their tablets in the morning. They might feel a bit choking. So there is a fluctuation in that way, and sometimes temperature fluctuations can affect your myasthenia gravis. If it is too warm in your house, that can make them feel weaker. And patients do, you're right, as the day goes by, depending on the activities they do, they become symptomatic. The patients do tell me that by the time they go to their work, they find they're strong, and because they have walked that distance from bus stop to the work, they're struggling to go up the stairs. This is incredibly distressing to patients, and those who don't have myasthenia cannot even fathom how that might be feeling. So yes, even patients with minimum symptoms can be feeling like that, and the fluctuation, as opposed to who are completely rendered symptom-free, what we call pharmacological remission. There is also this other element in myasthenia gravis patients. They can have, we talk about fatigability. That means exertion-related loss of muscle strength. In addition, they can also feel fatigue. Their strength might be there, but there could be a significant sense of feeling that they're working on half the engine or half the battery is firing on that day. We talk about fatigue. We talk about central fatigue. That means it's happening somewhere within the brain, and then and the peripheral fatigue, where the neuromuscular junction is becoming weak. So the neuromuscular junction, even if that is working stronger, there is a component of central fatigue, the lack of energy kind of feelings. So that could also fluctuate depending on the mood, the hydration levels, there's infection on board or not, and other environmental factors. So there's a fluctuation can happen at various levels.
And Amanda and Tracy, welcome to share your experience of that element of living with the condition. But I also wondered, is that one of the sort of common things that's shared with you in terms of Amanda through the support group, and then Tracy through kind of your support role, and what other themes sort of are the key things that people sort of come for advice and support with if they're living with myasthenia gravis?
Do you want to go first, Amanda?
No, you by all means, Tracy.
Okay, so yeah, it's a strange one. I talk about it quite offhand because it's something I've lived with for a very long time. But one thing that brings you right back home to the fluctuation is when you've got a new member recently diagnosed, and one day they can do what they normally do, go for a walk the dog, garden, do their job, and the next day they can't make a cup of tea. And it can be very hard to explain to somebody that, you know, you are going to have ups and downs. It is going to be dependent on the weather, how your sleep is, how your health is, what stresses you have going on in your life that you may not even be aware is affecting you. It's a very, very tricky thing to kind of get your head around, and 20 years in, I'm pretty sure I still haven't. It can be scary. I think it's quite a big word, but it's actually still happens to me now. If you plan something, am I going to be able to, even just down to shopping in a supermarket, am I going to be able to get to the checkout and get back to the car? And it could be something as simple as that, to having a holiday, going to weddings, seeing friends. And it's very, very common. With all of the members, they talk about fatigue, they talk about the unpredictability, they talk about the not being able to plan and the not knowing. And that's certainly my personal experience, you know, as well as many of the members at MyAware. But that's very hard to explain to somebody that's recently diagnosed, that's gone from having a very, very normal life, you know, for them, to all of a sudden, I can't work, I can't drive, I'm relying on friends, family, partners, you know, I can't prepare a meal or prepare a drink for myself in some cases. Can't see, everything's double vision, can't, you know, watch telly, read a book, those sorts of things. So it's yeah, it's tricky to manage, but also, you know, tricky to understand.
It is. I can add no more to that about the physical side. There is the mental side of it as well, the general mental, general health, that there is no support that way as such. Everyone thinks of the physical side, but if you've got a broken arm, people can see it. If you've got a broken leg, people can see it. However, because you can't see it, and it's as you say, it fluctuates, people are like, well, what do you mean? You know, this isn't, how do you, you can't articulate it to people that don't understand it. And unfortunately, you have the workplace, the family, friends, they do not always understand, and we need to see that side. We need to see that side looked at more. We need to understand that more. General well-being is something that will help with MG, and the stress exacerbates it. General well-being exacerbates it. So we need to understand that more, publicise that more. They go hand in hand. That's all I would add, because there is nothing else I can add. Physically, it affects everybody, as Tracy was saying, but the general mental health well-being needs to be looked at as well.
I think just to add to that, the unpredictability between member to member or patient to patient. I'm unfortunately one of Chana's not great in the morning people, whereas most of our members say they're better in the morning, and as the day progresses, I'm the other way. I work with a colleague who also has the condition. He's the opposite to me in many things that I do. So when we're giving our experiences, both Amanda and myself, you will hear from many other members who have completely different experiences, yet diagnosed with the exact same condition and treated with the exact same medication. But yeah, the fluctuation is there, but the side effects and how your symptoms can be very, very different person to person.
Absolutely. To even just, some of us can speak, some of us can swallow, but others can't. You know, your eyes. But then you could have generalized MG, which makes you just weak, but it could just be your eyes. And I don't think people can fully understand or quantify what is going on with your body. With MG, it's we can't say it enough. It is so unpredictable.
And I think the kind of two things I sort of take from that that exchange, thank you for sharing your experience. The answering Chalice as well, the sort of the fatigue and the sort of the tiredness of living with myasthenia gravis, and that's common across a lot of the conditions that we cover at Muscular Dystrophy UK. So last year we produced some fatigue guidelines. So for that reason, actually, when we went and spoke to people about their experience of living with a muscle wasting condition more broadly, a strong word that people came back with was just it's exhausting, it's tiring. Just every day is tiring. And the other thing that pulled out, which I think speaks back to kind of the role that MyAware and MD UK have in the treatment of poses. Actually, I think an area we really have helped NICE understand more about is the psychological impacts on carers, and what it's like to have what that unpredictability is like for a loved one, as well as the person living with the condition. So that's a really important point to note.
Absolutely. I always, sorry,
go on, Amanda.
Just my last thing is, the carer cares. Who cares for the carer?
Mm-hmm. Yeah.
That's all I was saying.
Thank you. We've got two final questions, unless anyone else wants to sort of come in from the group on the sort of Q&A thing. So they're both quite specific. So I'll take them one at a time. It may well be, I think, Chana, it's you the first responder to each of these two questions, and then I'll wrap up unless it has some final comments. But the first one was around kind of someone's interested in the respiratory effects and whether there are any respiratory aspects to myasthenia gravis. Someone who said they've experienced something they've seen some stuff on Facebook groups that don't constitute a flare or a crisis. So is there a kind of underlying, or sort of not underlying, an ongoing respiratory aspect of myasthenia gravis for some people?
Yeah, absolutely. As Dr. Laite mentioned, there are increased number of neuromuscular junctions on the diaphragm, as well as intercostal muscles. And the intercostal muscles particularly can be at risk of being affected by myasthenia gravis. And we know patients with generalized myasthenia gravis can have respiratory weakness, and it's one of the major concerns of an impending crisis in some patients, where those muscles are significantly weak. But in addition to that, when someone is suboptimally controlled, they can become short of breath because of for two reasons. One is it could be that there is some degree of involvement of the respiratory muscles, and secondly, it could be that people with myasthenia gravis constantly adjust their what they call the norm. They always go into a new norm and recalibrate what they can do, and that is how some patients cope, because that's what they call their norm, and their norm is significantly lower than what they did a few months ago. So likewise, they also recalibrate their exercises, and they exert less and less and less, so that they don't become short of breath. So that sometimes can lead to deconditioning of their muscle endurance. That could also contribute to shortness of breath. In addition to that, there are some patients where particularly the respiratory muscles are affected. They're particularly short of breath, but they might not have the double vision. They might not have the swallowing, chewing problems, or arms and legs weakness, but particularly the respiratory weakness could be predominantly their main symptom. Now, why that is happening could be the fact that there are neuromuscular junctions in the chest wall muscles or the intercostal muscles. It could be particularly at risk. In such situations, I have started non-invasive ventilator or NIV support for patients, particularly if they are deteriorating overnight. But that's only a small group of patients. There is another final component of patients that I would like to mention, is those who feel that their respiratory muscles are weak. They might not necessarily have weakness, but there is a perception that their respiratory muscles are weak, and that can lead to what we call dysfunctional breathing. There might be a need for working with a respiratory specialist, a physiotherapist, or a counselor sometimes, to be able to overcome those difficulties. But that's a smaller, a rare group of patients. But we need to be aware of all this spectrum of conditions that can make people feel short of breath in myasthenia.
Thank you. Amanda and Tracy, have you anything to add on the respiratory? Something that's something you've experienced yourselves, or something you've advised people with?
Yeah, and many moons ago, when I was first diagnosed, I was told that myasthenia doesn't cause breathing problems. So it shows kind of how far we've come now, because a lot of our members do report that they have problems with the breathing, and maybe the neurologist isn't of the same opinion. So we are aware that the myasthenia specialists are very versed in this, and perhaps not every neurologist is aware of everything. Obviously, lots of members see lots of different specialists or different clinicians, but yeah, it's certainly something that is very topical for our members, and one of the the reported issues that they're having.
Yeah, I mean, I'm lucky. I've never had any real breathing problems myself. Swallow is one of my main problems, I will say. But I have met a couple of people who have had severe respiratory problems and fine one day and not the next. And again, it's terrifying to see, but with support, they have got better. And but until the next time, you see, this is the problem. But yeah, no, I've been quite lucky, to be fair.
And then the final question we had in advance, and our final question as things stand, is quite a specific one. But are there any medications that people with myasthenia gravis should avoid, or is much of that down to the individual and talking with their kind of clinicians?
I think it's a very individualized situation, but in broadly, myasthenia gravis patients should inform their GP, or if they have any procedure done by the dentist or they by a surgeon, to inform that I've got myasthenia gravis. Certain drugs should be avoided, so that the clinicians or the practitioners could double check. MyAware has a list of drugs that should be avoided, and anesthetists and clinicians are aware usually what drugs to be avoided. As general rule of thumb is best to tell whoever who's going to give you a new drug, I got myasthenia gravis. My condition and my drugs that I take can interact with some medications, particularly the antibiotics. Antibiotics that what we call macrolides and another group of drugs like aminoglycosides. These are scientific terms, but common drugs are like gentamicin or erythromycin, like medications can interact with myasthenia gravis because they can affect how the neuromuscular junction transmission works. What Professor Leite was explaining earlier, that ion channels, how they work, can be affected by some antibiotics. And then also there are certain medications that we give for patients with heart conditions, can interfere, but it doesn't interfere with everyone, but it can happen in some patients, particularly if your myasthenia is active. And the risk is less so for patients with mild or well-controlled myasthenia. But please do discuss with your practitioner, because how your myasthenia might react is different from patient to patient.
That's great. I think that's it for our questions. I think I'll start to draw us to a close now. So a huge thanks to everyone for joining us, and a huge thanks to the panel. It's been a great discussion, a very broad ranging discussion. I do feel I should give Amanda and Tracy the final word as the two people living with the condition with us. So yeah, Amanda, is there anything we haven't covered that you'd like to sort of share or ask, and then I'll move to Tracy, and then I'll say goodbye. So Amanda, you first.
No, I don't think so, actually. I think it's been a very, very good seminar. So apologies, but I haven't got anything else I'd like to add other than, people don't give up. Don't give up. Speak to your clinician. If you've got any doubts, go to your GP. I don't feel that there's enough out there to help somebody with any neuromuscular disease. With MG, it's very, very difficult, but don't give up.
That almost should be the final word, but I will go to Tracy for a final
Sorry,
word.
Tracy. Sorry.
As compelling as Amanda's wrap up. That was fantastic. Thank you.
Sorry.
I'll try and end as well as you, Amanda. Just to say,
No.
first of all, thank you for inviting me. It's great to be involved in this. They're really exciting times out there for people, living with the condition, because there's a lot going on, and certainly a lot more than has in the past. So we're certainly really, really excited at MyAware, and it's one of those things where watch this space, I think, because I think there's a lot of people working to get some new things on the horizon, and obviously we're there in support as well as yourself. Support@myaware.org if you want to get in touch if there's anything we can help with. And I like our partnership with muscular dystrophy. It's going very well, and it's lovely to be a part of it.
Thanks, Tracy. Channa, you've got your hand up to have the final word.
I'm sorry, that's not the intention. My intention was to thank you, MD UK and MyAware, for your support and for the strength behind the myasthenia gravis patients. Thank you very much.
Thank you. Professor Leite, you've come back on, so have you got something final to say?
I have been sitting here delighted while I was writing a letter, delighted to hear all of you. I knew Channa was going to be wonderful, and I have really appreciated all the comments of particularly the patients, and I can't agree more with what they say about unpredictability, the impact in their life, their families, those around them, the hidden disability that nobody sees, and the impact on the mental health of many patients. Some of them are strong and may not show their frustration, their depression, etc. But we know that that is there, and it's a huge problem for these patients. And so I heard everything, and I really appreciated. And Charlotte, I heard about the appraisal, etc., and how much or how little you can say. You can say lots, but you don't have much time to say so much that is needed. So I really appreciate it, and we'll keep pushing to get the best treatments for all of you.
Thank you, everyone. That's a good note to end on. Yeah, and I think collaboration is the heart of what we do at Muscular Dystrophy UK, and I think it's fantastic to be collaborating with not only the clinicians but also with Maya as well. So thank you, Charlotte. Thank you, Professor Light. Thank you, Amanda, Tracy, and Charlotte. I think Charlotte and I have a meeting tomorrow, even. So I'll see.
Yep.
Charlotte, I shall see you tomorrow.
Yep. See you there.
Thank you
Nice
to
one.
my colleague Andrea for chairing the research part of the session. This recording and all others will be available on our website, or others are already available. So this one will join that suite of recordings shortly. So a huge thank you to everybody. Thank you to our sponsors. Enjoy the rest of your afternoon, everybody. Thank you again to the panel.
Thank you.
Bye bye.
Bye, everyone.
Thank
Bye,
you
Isabel.
very much. Have a good afternoon.
Bye-bye.
Bye.
Bye.
Bye, Isabel.
Bye.